Hi, everyone. Welcome to tonight's free webinar all about the evidence on prenatal cervical exams and membrane sweeping. Welcome, welcome. We are so excited to have you. I'm going to take just a minute to get everything set up and make sure our team is in the room. We've got, make sure we got our interpreter set up.
And the chat too, Rebecca.
Oh, the chat.
There we go. Nope, it looks like it's good.
Is it working? All right.
Yes.
Go ahead and set your chat to everyone and then introduce yourself in the chat, please. That would be great. And so change your little blue button to say everyone, and then let us know where you're joining from. And I'll also pull up the poll, so you can also let us know what you do in the birth world. And I'm going to get let me see if you see Sarah Aylshire. Could you raise your hand if you're in the room? And I don't see Sophia yet. Okay. Awesome. Wow, we have so many people joining us tonight. I think we had like 2,000 people registered. So I'm not sure how many will be in the room. I think we have room for around 500, I believe. So if you got here early, good for you. Hi, Sarah. Hold on just a second. I'll share my screen and then I'll get the interpretation going as well. So welcome to the webinar about the evidence on cervical exams. If you're joining us via the recording, you might need to fast forward past where we're getting our room settled here for the live presentation. So you can access the live transcription during tonight's training. If you have any problems with that, let our team know in the chat. We also should have live Spanish translation tonight. So please help give me a minute to make sure that's our interpreter is here and that's functioning. The recording will be available through October 18th. So we will take about an hour and 15 minutes if we want to get through the questions. And so if you have to step out early, that's fine. You'll have the recording probably starting tomorrow through October 18. And let me just check and see how it's going with interpretation. Shantae, I don't see Sophia in the room, so let me know when she gets here. Awesome. Okay. A few disclaimers. Watching this webinar does not mean we've entered into a patient care provider relationship. Nothing in this training course should be construed as medical advice. Please talk with a care provider before putting this information into practice. And although we do our best, the content is not guaranteed to be 100% accurate or up to date. Also, as a content note, we will be talking about pelvic exams, as well as unconsented exams, unconsented medical procedures, preterm birth, and racism. Our expectations for you all who are attending this free webinar, please do not put any outside links in the chat. Only Team EBB members are allowed to put links in the chat, and they will delete any links that are not authorized. Also, please put your questions in the Q&A box as we're talking. We will attempt to answer several questions during the Q&A, time permitting. But if your question goes in the chat, we might not see it. Also, please do not share any medical advice. So don't tell people what to do with their pregnancies or births. All advice will be deleted from the chat. Please keep the chat respectful and kind, and attendees who do not meet these expectations might be removed from the webinar room per our team's discretion. So we do have an amazing team of EBB staff who are here to help us tonight. One of those is Sarah Aylshire, our research fellow at EBB. Sarah, do you want to introduce yourself really quickly? Oops, you're on mute.
Oh my goodness, let's try that again. Hi, everybody. My name is Sarah Aylshire. I am a EBB research fellow. I'm joining the chat from Danville, Kentucky, and when I'm not doing this, I'm a doctoral candidate in anthropology. So I'm super excited to be here and super excited for this presentation.
Yes, I love having Sarah co-teaching with me. We have some great research fellows at EBB right now. Yes, we got people in Florida. So I'm really thinking about you and all as well as those of you who have friends and family there. My best friend is right where the eye is about to hit. So I'm just like furiously keeping track of where she is and what's going on. So I know some of our minds and hearts may be elsewhere tonight. And if you just can't talk about the subject tonight, that's fine. Like I said, the recording will be here for you later. Also, yeah, we'll be talking about some of the things we'll have at the end if you can stick around. So let me end the poll about your role in the birth world and share the results, and then we'll get to that next question on the screen. So it looks like we have a lot of doulas here tonight. So welcome to all the doulas, midwives, nurses, a few nurse midwives, some parents who are expecting, lactation workers, childbirth educators, massage therapists. If there's something on there that I didn't list, you can put it in the chat. And we have some students here as well. Sometimes we'll have entire groups of students who are listening together, and that's always fun. So welcome to everybody. And yeah, awesome. Okay, so my next question has to do with when do OBs start offering or recommending cervical exams in your area? So if you're attending live, you should be able to fill out this poll and scroll down because you'll see there's also on request only and never. And then you can keep scrolling and answer question number 2, which is the same question, but it's about midwives. So when do midwives start offering or recommending cervical exams where you live? So go ahead and fill out that survey. And yeah, make sure you change the blue drop-down button from host and panelists to everyone so we can see your comments. Yes, Bonnie's joining us from North Carolina. Yes, we have, many of us have friends and family there as well. Western North Carolina, Eastern Tennessee. So it's been a rough couple of weeks here in the eastern half of the US. Okay, I'm gonna end the poll.
Rebecca, Sophia's here.
Okay, perfect. Okay. We will get, oh, you've added her? Okay. Let me grab the interpretation. I've almost got it ready. Hold on. This takes me a minute. Okay, Sophia, you should be able to interpret now. So if somebody would like to listen in Espanol and test it out for me, go ahead and try it out. You should be able to click on the little globe so you can get the live translation from our wonderful interpreter. Okay, it's working. Great. Okay, so I'm going to share the results from the poll. So looks like, wow, 37% say OBs start offering cervical checks at 36 weeks, and then 38 weeks, around 23%, and then fewer later. And then the midwives, it looks quite a bit different. It's kind of less than 10% each of the early weeks, 13% at 40 weeks. And half of all you say that midwives in your area only do a cervical exam if it's requested by the client. Okay. As we get going, you're welcome to take a few screenshots to share on social media of your favorite slides or of parts that you found interesting. Go ahead and tag us at EB Birth. Let everybody know you're continuing your education or you're learning more about birth and pregnancy with evidence-based birth, and we'll do our best to try and reshare as many of those as possible to uplift you as well on social media. So a little bit about how our content is going to work. We're going to do some teaching, and then we will talk about more resources you can get at Evidence-Based Birth. Then we'll go on to questions. At the end of the Q&A, we will provide you with a handout for those of you who are attending live. And we're going to do some fun giveaways. We have a spinny wheel we'll spin. And Shantae, you can put in the chat. I can't remember what the prizes are, but just let people know what they're eligible to win by being here for the spinny wheel. And this is what we're going to cover: the evidence on prenatal cervical exams, I'm going to be focusing on the cervical exam. Sarah is going to be teaching about the evidence on membrane sweeping. And then we're going to talk about how to advocate for yourself, get informed consent, and we have a bonus role play. So in about the hour, that's what we have together. We'll probably take an extra 10 or 15 minutes to do questions, and then we'll do the handout. So if you all are ready to get going and you're excited to learn this evidence, go ahead and put a big yes in the chat to let us know in whatever language or however you want to tell us to get going, and we will start. Okay, there's a lot of you in here now, so that's a lot of yeses. All right, so I have your consent to move forward, so we will. All right, some background first. With cervical exams, this is a type of pelvic exam in which the provider is assessing the cervix. This can occur during a routine checkup, during a cervical cancer screening, or during labor. So routine like prenatal checkup, or maybe if you're having some other kind of GYN visit. So interchangeably, you'll see the terms used: cervical check, vaginal check. You might hear vaginal or vag exam, pelvic exam, and digital exam because you're using the fingers or digits to check the cervix. Depending on the circumstances, depending on where your cervix is located, your personal history, and the skills of the provider, sometimes these exams can be painful or uncomfortable. So what a cervical exam can identify is cervical dilation. And that's often what most of us, when we're pregnant, we're really curious about. And I have my little handy dilation wheel. So a lot of us want to know, like, have we started changing yet? We also are interested in effacement, and that has to do with the thickness of the cervix. So that top picture A, that's the baby's head coming down, and I have a little knitted uterus here as well. This lighter blue part is the lower uterine segment and the cervix. It's the lower part of the uterus. And you can see it's kind of thick right now and tall or long, you might say. And same as in picture A. So the provider would be inserting their finger or fingers up through the vaginal canal, feeling the cervix. In that picture A, the cervix is closed. It's not even dilated to a 1. In picture B, you see the vaginal canal, and then you see that the cervix has kind of gotten thinner. See how it's not as thick? And then in picture C, it's almost all the way thin. There's just like a little edge right here. And then in picture D, you can't even really feel the cervix anymore. It's kind of melted away into the sides of the uterus. So the contractions have pulled it up and so that the baby's head can come out. And so one way when I'm teaching this with students is I'll use a bottle that looks like this. Imagine this is the cervix. So it's thick and nothing can really kind of get out through there. You need that cervix to ripen or get thinner, so it's more like a peanut butter jar. So you can also check the baby's position. That can be done through an abdominal palpation where you're feeling with hands or an ultrasound, and you can check for cervical abnormalities. Cervical position has to do with how far forward or backward it's located in your body. Consistency, is it like, the tip of your nose, or is it more like your earlobe? And then fetal station, meaning like where the baby is in relation to your pelvis. So it does give you some information. The Bishop score is another thing you can get from a cervical check. So this is based on the results from a vaginal exam that's using 5 measurements of ripeness to determine how ready the cervix is for labor. And like many things in pregnancy and birth, this was named after a man. This was an OB in Pennsylvania who at the time, Pitocin or oxytocin given through IV became popular. There were lots of women who wanted inductions, lots of OBs who wanted to induce labor electively or for choice. And he found that a lot of these inductions did not go well. So he kind of developed some guidelines, this score that helps give you an educated guess about your chances of having a vaginal birth if your labor is going to be induced. And so you calculate the Bishop score. You can use a calculator online, or you can use a written one like this. look at the dilation, the effacement. So a 0% effaced would mean, again, you have like the full thickness of the cervix, while 100% effaced means the cervix has completely thinned away. Station of the baby, where they are in relation to the pelvis, the consistency of the cervix, and where it's positioned. So if the score is 8 or higher, then chances of a vaginal birth with an induction are pretty good. A score of 6 or less means the cervix is unfavorable for an induction. The middle range scores are not as clear. Scratch that. I said the score of 7 is not clear. That was my mistake. So it should say the middle range score of 7 is not clear. Anything below a 6 or below is unfavorable. And then some propose adding 1 to 2 points for a prior vaginal birth, because if you've had a baby before, that's usually a pretty good indicator that an induction will work. So I have a quick quiz question for you. I'll pull up. Just give me a second to bring it up. So, which of the following statements are true? Cervical checks detect the chances that labor will start in the next week. Prenatal cervical exams are the standard of care for obstetric and midwifery care, both A and B, or none of the above. All right. Got hundreds of people clicking the survey results or the quiz results. I'm going to go ahead and end the poll and share the results. Okay, most of you got it correct. So the true answer is none of the above. Checking the cervix does not give you an indication of when labor will start. It can be useful to, as we talked about earlier, if you're having an induction, to know how easy it will be to induce you. If your Bishop score is not favorable, you might need some additional medications or procedures or time for the cervix to ripen. And it's the standard of care for obstetrics, but not midwifery, I would say. All right, Sarah, I'm going to pass it off to you.
Okay, so go ahead and in the chat, if you'd like, you could share about how often do providers in your area perform prenatal membrane sweeps?
Okay, and I also have the
Sorry, it's a
poll, so I'll
quiz.
pop that up. Yeah.
Cool, thank you. Much better. I'll give everyone here a couple of moments to respond. Oh, wow. Okay, let's see. Oh, wow. Okay, so it looks like the largest number of respondents say it depends on the provider. Some of the time, coming up here, about a third there, most of the time, 24%, rarely, and all the time, similar to one another. And here in the chat, seeing some people saying often without consent, and then fairly often, and also by request. So kind of covering the board here. So what is a membrane sweep? And this is, likely review, but membrane sweeps are a procedure where a healthcare provider sweeps a gloved finger across the membranes that connect the amniotic sac to the wall of the uterus. Doing this can help the body to release a hormone-like chemical called prostaglandin. Prostaglandins help soften, thin, and dilate the cervix in preparation for labor. That's why membrane sweeps are considered to be a form of labor induction, which we'll talk about a little bit in a moment. Interchangeable terms for membrane sweeps are membrane sweep, membrane stripping, and intracervical exam. And as the poll responses showed, as the comments in the chat showed, these are commonly performed procedures done by providers in up to 1 in every 3 pregnancies at term. So what is the purpose of a membrane sweep? They're intended to help labor begin sooner, and they're technically a form of induction. They're technically a form of induction called mechanical induction, alongside pharmacological and surgical modes of inducing or causing labor to start. Why are we talking about membrane sweeps here? Because providers, in some cases, and someone in the chat alluded to this, will consider membrane sweeps to be part of a cervical exam. But as we know, these are 2 separate things. A cervical exam and a membrane sweep are not one and the same. And if you're consenting to a cervical check, you may not be consenting to a membrane sweep. Compared to other modes of induction, membrane stripping is popular because it's relatively simple, it's a low-cost procedure, It doesn't require monitoring. If you have a home birth midwife, she could do it in your home. And for those reasons, if you're interested in induction, it might be a first stop along the road. One more point to mention before we move on is that membrane stripping is often experienced as being painful or uncomfortable. And we'll talk about that a little bit more later in the presentation. So, do you have any thoughts about prenatal cervical exams and membrane sweeping that we haven't covered yet?
Yeah, and while they're posting in there, I thought I could show, I do have for, some of our expecting parents here who might not understand all of the medical terminology. We do have our uterus here with there's the baby's head and there's the membranes there. So the membranes, there's a 2-layer membranes and the chorion and the amnion, and you'll hear those words later. So when she was talking about membrane sweeping, kind of separating the uterus, stripping away that from the membranes. So it looks like some of the things people are asking, potential of accidentally rupturing the membranes, how effective are they? Are there any safety concerns? What if the patient doesn't want it? Why can sometimes the experience be so bad? So we'll talk more about those as we're going through, and we're going to cover all of that. Okay, so the evidence on cervical exams. Some of the first research we have on this, and the only research, comes from the 1980s and 1990s. So the first randomized trial on prenatal cervical checks was carried out by Lenahan et al. And they had a research question. It was a group of OBs. They wanted to know, does weekly cervical checks increase the risk of your waters rupturing at term? So we call that term prom, which I'll explain more in the next slide. So they had 349 women in this study, randomly assigned to one of two groups. They could either be in the no exam group, where they had no cervical checks until 40 or 41 weeks, when an exam could be done, but only if the provider thought it was medically necessary. Then they had a weekly exam group that had weekly cervical checks starting at 37 weeks. So similar to what a lot of you were saying, cervical checks in your community tend to happen with OBs at 36 or 37 weeks. And you can see what they found is on the right-hand side, the no exam group ended up with a 6% chance of their waters breaking before the start of labor, while the weekly exam group had a 3-fold increase. The risk was 18%. That's a pretty substantial difference between groups. So what is prom exactly? We've talked about this a lot in evidence-based birth, especially in the year 2023. We came out with several podcast episodes and an updated signature article. But pre-labor or premature rupture of membranes, which we call prom in the birth world, it's different than the dance. It is defined as your water breaking before the start of labor. We can have prom at term or preterm prom. Prom happens in about 10% of term pregnancies, but that number is old. We do have research showing that the risk of prom goes up with climate change, that rates of prom are much higher during periods of extreme heat or extreme cold. So these extremes of weather that are prolonged can stress the bodies of someone who's pregnant. And physicians may recommend induction with prom. So it can definitely mess with your birth plans a little bit. If you were hoping to go into labor on your own and then you have prom, it might be that you have an induction recommended to you. Now you have the choice to refuse that, but it does complicate things, especially if you have group B strep, if you've tested positive for group B strep. And on the right, it shows you the percentage, like your chances of going into labor on your own if your waters break before the start of labor. So a little less than half will go into labor within 12 hours, 77% within 24 hours. But if it's your first baby, it's more likely to take longer. So prom doesn't just interfere perhaps with your birth plan, but it can also increase the risk of infection. So earlier when I was mentioning the membranes, the chorion and the amnion, you can have something called chorioamnionitis, which means infection of the membranes. And before we used to do testing and treating for group B strep, BACA, rates of that were about 4 to 8% if you had prom. Infection in the baby is also a risk with prom. rates are about 2 to 3%, because the membranes kind of create this protective barrier around the baby. And if you no longer have that barrier intact, you can have infection. And there are certain things that increase the risk of infection, including group B strep, but also many cervical exams in labor can also increase the risk of infection with PROM. So the next study we have on cervical checks was published in 1992 by McDuffie et al. And they also wanted to know, do these prenatal vaginal exams that all obstetricians are doing, do they cause PROM? So they had a slightly larger study. They enrolled 604 women who were pregnant at 34 to 36 weeks, randomly assigned them to one of two groups. There was a weekly exam group starting at 37 weeks and a no exam group that only got an exam if medically necessary, such as right before an induction. They ended up finding no differences between groups in any health outcomes, including PROM. And their conclusion was, quote, though we found no harm from routine cervical examinations, we could also find no benefit. So really interesting that the only two studies we've ever had on this, prenatal checks during pregnancy, have found no benefits. So why do you think, though, one study had a higher risk of PROM with the exams while the other did not? Well, here's the deal. There's always a reason for some of these discrepancies. In trial number 1, if you look at the methods of how they carried out the study, the doctors might have been doing membrane sweeping during the vaginal exam because that was standard care. And researchers did not track, they did not measure how often this happened, they did not control for it in the statistics. In trial number 2, membrane sweeping was not supposed to be done. So the doctors knew they weren't supposed to be doing it as part of the study. So I think what we had, if you go look back to those original results where study 1, they found much higher rates of PROM, might have been related to membrane sweeping happening during the exams. We'll talk more about that later with Sarah. But the bottom line is there were no benefit to the prenatal cervical checks other than satisfying your curiosity. And the potential harm could be PROM, but the evidence was conflicting, and the risk is probably higher if you have membrane sweeping with the exam. Another question I have, I'll pull up a poll so you can enter your answer. Have you ever seen or heard of a parent receiving additional exams because the student was in training and needed to practice? Yes or no? Okay, let's end the poll and see what you all said. Okay, so 73% of you have seen or heard of a parent receiving additional exams so that a student can practice. So let's talk about that. This was an article published in the New York Times in 2020, shedding light on a very difficult topic, but one that needed to be discussed. And that is that medical students were being asked by their schools to perform pelvic exams on unconscious patients while they were under general anesthesia, and the patients did not consent to that. And this was a woman they gave as an example. She had a stomach procedure. After she woke up, the resident was like, by the way, you're getting your period. And she was like, how do you know that? And then she figured out that they had been doing a pelvic exam on her while she was under anesthesia. And people, have been horrified, but the truth is this has been going on for a really long time. And maybe it's not the culture in some places around the world, but in other hospitals, it very much was the culture. So what ended up happening after that is a working group that included patients and providers was very concerned about this. So they did the first US-based survey of unconsented intimate exams. And I think they're purposely using this terminology of intimate exams to explain that this is like a violation of like a most intimate part of your body. And they calculated that over a 5-year period, potentially 3.6 million American women and men had either unconsented pelvic or prostate exams, which are also quite invasive. And they found that Black patients were 4 times more likely to report having received unconsented exams. Interestingly, both men and women reported having these exams unconsented at similar rates. But I don't believe that they were not specifically looking at pregnancy in this. As a result of this study, there were some HHS rules in the United States published forbidding unconsented exams during general anesthesia, but nobody has yet addressed at the guideline or policy level unconsented or exams that people are pressured into during labor. Looking at the research on this, we did find one new study. There wasn't a lot on this, but I thought this was interesting, where practitioners trying to decrease the number of exams that you're getting in pregnancy or during labor. How it typically works is that the student or the resident will, first they start with plastic models, and then they're going into the room and doing it on a real person. So the patient gets one exam with this trainee, and then the training provider comes in and does another exam. So you basically are always getting double the exams because you're comparing results. So that basically results in doubling the rates of cervical exams for some people. And as we know, people who are more likely to have this, if you're a doula and you've witnessed this, it's often people who are younger or who are Black or who are on public insurance might be more likely to have the students practicing on them, essentially. So I think this was an interesting way. It's like a low-cost model with a container and different ingredients where they can insert their fingers in and see how dilated and how thinned the cervix is and test the results to kind of get practice without always having to practice constantly on people, but getting a little bit more practice with the models. All right, Sari, you want to talk about the evidence on membrane sweeping?
Absolutely, yeah. So now we're going to move on to talk about the evidence on membrane sweeping, and we'll start by talking about the most recent Cochrane review on the topic. The aim of this review is to find out if membrane sweeping is a safe and effective way of inducing labor at or near term, and if it was more effective than other formal methods of induction. So they looked at 44 studies in total. 40 of these studies compared membrane sweeping to no treatment, and in total, there's roughly 6,500 participants across studies. The studies looked at a wide range of countries, including high, middle, and low income. Overall, the researchers described all of the findings as, speaking about them as a group, low quality, meaning that there were some questions or some approaches that were sort of left unaddressed by the existing research, and saying, there's some new directions that researchers can take. They found that patients who were randomized to membrane sweeping were more likely to experience a spontaneous onset of labor after the fact, and were less likely to experience another form of induction. However, they found little to no difference between membrane sweep and no membrane sweep in certain outcomes and in certain risks, including the likelihood of cesarean birth, spontaneous vaginal birth, maternal death, or newborn death. So the bottom line, according to these researchers, is that membrane sweeping might be an effective way of achieving labor or achieving the onset of labor, but there are still questions that remain as to whether there's an optimal number of membrane sweeps and when the best time in a pregnancy might be to facilitate the induction of labor through membrane sweeping. And now we're going to talk about a couple of the specific subtopics that researchers have focused on when it comes to membrane sweeps. And we'll start with membrane sweeps and induction, because as we know, membrane sweeps are a form of induction. So a couple of studies here looked at membrane sweeps and induction. They found that generally sweeping at roughly 41 weeks decreased the chance of continuing on to a post-term pregnancy from 41% to 23%. They found that membrane sweeps reduced the time between randomization, or when people were assigned to different categories within the study, and birth by 4 days. And they found also that membrane sweeping was associated with a shorter duration of pregnancy and decreased chance of pregnancy continuing at 41 to 42 weeks. There's lots of factors that impacted pregnancy and impact whether or not any form of induction, including a membrane sweep, would work. So that's something that's important for us to remember when we're considering this research evidence. Moving on, we'll talk a little bit about membrane stripping and cervical status because that's an important part of the procedure itself. And this also bears on the type of research that people can do. If your cervix is closed, you cannot have your membranes swept. So most of the time in research, if participants are assigned to membrane stripping or membrane sweeping and they have a closed cervix, they may get what is called a cervical massage. And this can be from anywhere from 15 seconds to 2 minutes. This variability contributes to that low quality of evidence that the Cochrane Review referenced on the topic. That's because there's a lot of variability in how researchers handle this question of what do you do if you want to sweep someone's membranes and you can't, and that increases the variability between different studies. Moving on, we're going to talk again a little bit about membrane sweeping in prom. This was a topic that came up quite a bit in the chat. So Hill et al. Looked at membrane sweeping and the risk of premature rupture of membranes or prom. In this study, 300 women were randomly assigned to either have a cervical exam or membrane sweeping every week, beginning at 38 weeks. In the membrane sweeping group, again, this question of whether or not the cervix is opened, if a cervix was less than 1 centimeter dilated, women were given instead a cervical massage. In both groups, there was no difference in the rate of prom. However, when you look at the subgroups in the study, things can be different. So when researchers only looked at participants who were more than 1 centimeter dilated at the time of the intervention and so could have their membranes swept, the membrane sweeping group was more likely to develop prom. And when we think about what a membrane sweep is, this makes sense. You are inserting the finger, you're sweeping the membranes away from the uterine lining, you're releasing the prostaglandins. That type of mechanical interference could potentially result, maybe unintentionally, in the rupture of membranes. Now we're going to move on to another important topic, which is membrane sweeping and pain. So many people experience membrane sweeping as painful or uncomfortable, as is the case with any type of medical procedure involving the cervix. However, other people may not. That's because experience is variable. But it's vitally important for us to pay attention to the range of people's experiences of any type of procedure, particularly intimate ones like this, and when we're doing research, when we're talking about the research on this topic. So we're going to talk about the findings of a few different studies here. De Miranda et al. Found that most women reported that the procedure was somewhat or very painful and experienced more bleeding than the control group. Yildirim, and I might be mispronouncing this, found that women who were randomized to having their membranes swept experienced more bleeding and uterine irritability, meaning the uterus is contracting, but not in a rhythmic way, not in a way that would lead towards labor. Boulvain et al. Found that those who had their membranes swept had more bleeding and irregular contractions. And Wang et al. Found that 70% experienced significant discomfort or pain and gave an average pain score of nearly 7 out of 10. And in the Cochrane Review, only 3 studies actually looked at patient satisfaction. And those studies found that people who had membrane sweeps experienced them as being pretty uncomfortable, but because they had consented, they felt that on the whole, the benefits outweighed the harms, and most, but not all, would recommend it to other patients.
Yeah, I think that's a really good point, Sarah, about in these studies, you're getting informed consent. And we talked about the research on unconsented pelvic exams, but there is no research that I know of on unconsented membrane sweepings. We'll talk more about that in a minute. So just a quick summary of benefits and risks. So getting a cervical check and a prenatal visit towards the end of pregnancy may satisfy your curiosity or that of your provider. It may provide information that could be helpful if you're deciding about an induction, and it satisfies tradition and routine. The risks, there is an increased risk of infection, and that risk would go up if your membranes had already ruptured. If your membranes have not ruptured, there's not a lot of evidence on the risk of infection. It's more of a theoretical risk because the provider is pushing the bacteria from the outer part of the vagina up towards the cervix as they're moving their hand up the vaginal canal. There is a potential for trauma, especially for survivors of sexual assault. And there can be pain and discomfort depending on the situation, on the provider's skill, and the patient's comfort with the procedure.
So in that same vein, we'll talk a little bit about the benefits of membrane sweeps as well as the risks. One is that it satisfies tradition and routine. It's a common procedure. So if a person is interested in or considering an induction, this may be a common starting place. It may help encourage the onset of labor. It may help begin labor without requiring other forms of induction that may require more resources, more time spent in the hospital, more monitoring. So if you're already on that road to induction, it could be beneficial or could be something you might be interested in. However, risk factors include that you may not be able to receive a membrane sweep if your cervix is closed. The procedure can be painful, can cause bleeding, can cause that uterine irritability. There is that increased risk of PROM. It can lead to non-productive contractions. And as we've discussed, and we'll go into more detail here in a bit, it can sometimes be done without consent.
All right, everyone. So you all are listening and learning so much. What's one new thing you've learned about membrane sweeps or cervical checks that you didn't know before tonight? And then we're going to move on to the advocacy section, which is always, I love the evidence, but I also love talking about advocacy. So I'm excited for that. So go ahead and put in the chat one thing new that you've learned. Maybe you didn't know before. And I'll move on to the advocacy section. So, how to advocate for yourself and get informed consent. So, informed consent is a patient right, and it's rooted in our human rights. So, membrane stripping and vaginal exams are often intertwined. Like, you have to do the cervical exam first in order to do the membrane stripping. And so, because of this, it's really important that the client has received education about their health condition and options, understands the condition and treatment options, can decide on which treatments they want to receive, and provide consent to receive an intervention without being pressured or coerced. Also, they should have the right to refuse an intervention. So there is no evidence on how often true informed consent, where the patient consents to the procedure without feeling pressured. We don't know how often that occurs with vaginal exams or membrane sweeping in pregnancy. But I think most of the birth workers here have probably seen what I would call either unconsented exams or exams where the patient was clearly uncomfortable or didn't want it, but they felt pressured into it, or they felt like they couldn't say no. We know anecdotally that these procedures are done all the time without full non-coerced consent. I remember when I started evidence-based birth, one of the first stories someone told me, a friend of a friend, we were talking over pizza and she started telling me all about how she realized now that she had a membrane sweep without her knowledge, because she said she was 37 weeks, maybe it was 36 weeks. They were doing an exam. All of a sudden it got extremely painful. And then afterwards she was bleeding and cramping and she didn't know what had happened to her. And then she found out that it was membrane sweeping and she was horrified and it was very traumatic. And so I'm sure many of you, especially in the birth work field, have heard these stories. It's not been studied. It's really an area where we need more research so that we can show this problem. We know it's a problem, but the statistics would definitely help us argue our case. So parents need to understand that even if you want to be checked, you want your cervix checked, this could lead to an unconsented membrane sweep. So it really requires you to have a trusting relationship with your care provider and open communication. And it's really empowering just to know that this is a potential thing that could happen so that you can talk with your care provider about it. And we'll be demonstrating that in a little bit. Next week, we have a really incredible guest on the Evidence-Based Birth podcast. So please keep your eye out for the episode next week with Dr. Leslie Farrington. She's a retired obstetrician, and together with another doctor, Dr. Lori Zephyrin, and a doctor with her midwifery degree, Dr. Michelle Drew, they founded the Black Coalition for Safe Motherhood. Highly recommend this website. It's really focused on prenatal advocacy. So go to blackcoalitionforsafemotherhood.org. They have free videos, worksheets, and free workshops that any parent can sign up to take to learn how to advocate for themselves in prenatal visits. And they came up with the acronym ACT. So A stands for ask questions until you understand the answers. C stands for claim your space, make your wishes known. T stands for trust your body. And a second T for tell your story. Speak up if you don't feel well or are unsafe. And they go into a lot more depth on their website about different examples of this. So love the work that they're doing. Next week on the podcast, Dr. Farrington's going to explain all about it. She also is a hero of mine because she's out there trying to change practices among OBGYNs. So a true, you know, she's a worker and a fighter, and it's incredible to see what she's doing. Some tips from me and the other team members at EBB. These are tips we teach in the evidence-based birth childbirth class. So if you know upfront that you do not want a cervical exam, you do not need to undress when they ask you to. You can just keep your clothes on. And it's that simple. It's a way of trusting your body, telling them what you need by setting this boundary, like they can't violate you through your clothes. So that can be a helpful way, especially if you're nervous about saying no. And also, we talk about informed consent. It's pretty simple with the cervical exam. Like it can give us information. It might be helpful, but it doesn't change anything unless we're planning an induction. So most women know, and most pregnant people know if they want their cervix checked or not. They might want to have a conversation about it, but for the most part, people have an opinion. So trust your body and do what you want to do. Also get in the habit of asking at least 2 to 3 questions at every appointment. So if you're pregnant, this is like my top tip for you is to get some Post-it notes or sticky notes. And before every prenatal appointment, write down at least 2, maybe 3 questions that you have for your provider about pregnancy or birth or postpartum or breastfeeding or anything you want to ask about. And have that just one little sticky note in your hand so that when you're sitting there with your hands in your lap and they say, do you have any questions? You'll be like, oh, actually I do. And this way you can't forget them. You have the note, and also it doesn't look overwhelming. It's not like you brought a giant notebook with 20 questions. So ask your questions, and this is a way to practice using your voice. You can also have a companion or support person present who can amplify your voice, whether that is one of your parents, or it's your partner, or your sister, or a friend, or your doula. Dr. Farrington and a lot of other OBs that are really on board with this prenatal advocacy, they tell me that they love it when a doula is in the prenatal visit because then they can build a relationship with the doula as well. Start practicing saying no to other things in your life that you don't want to do. So a lot of us are people pleasers. I think in pregnancy, we can feel particularly vulnerable. We are worried that we will make someone upset when we say no. So practice saying no, thank you, or no, I can't do that today. And you can also practice saying your needs and your wants. I need this. I would like this from your family, from your coworkers, whatever it is. Just don't be afraid to voice your needs. All right, I think with those tips, we're ready to do some example scenarios. So I'm going to unshare my screen so I can pull up the script. Are you all ready to see a little play? Okay, I got to turn my camera off for just a second while I get set. And then Julie, I think you're up. Actually, though, you don't come on till the 3rd one.
I'll join you later.
Okay. All right. I got my white coat.
You're ready.
Thanks to Ricky from Team EBB for telling me to. So Ihotu is one of our beloved members of the team who is in graduate school now, but she did this one time when we did a role play and we all thought it was hilarious. So Ricky was like, you have to do what Ihotu did. Okay, so as you can see, I'm the provider and Sarah is at a prenatal visit. So I'm going to play a provider now. Are you all ready? Okay, we're going to do 4 scenarios. And each one's slightly different. Okay.
But
right.
they all start the same.
They all start the same situation. And yeah, so they all start like this. Okay, Sarah, now I need to check and see where you're at. I'll step out for a minute to give you a chance to undress from the waist down. There's a blanket over there for you to put on your lap. And once you're ready, go ahead and sit on the exam table. I'll come back in with a nurse and I'll see you in a few minutes.
Oh, what do you mean check to see where I'm at?
Well, you're at 37 weeks today. I want to check to see if you've dilated and where baby is.
I haven't had any contractions or anything, and everything kind of feels the same as it did last time.
Okay, so this is where scene 1 is going to go. Well, we won't know for sure until we check. It won't take too long. We'll have you out of here as soon as we finish the exam.
Oh, I'm a little uncomfortable with these types of exams. Is it really necessary?
If I can check your cervix, I'll have a better idea of where you're at. Once you're at term, you're at 37 weeks now. We like to do these checks so we can keep an eye on things until baby decides to come.
Okay, I guess if I have to, it's fine.
Okay, great. I'll step out now and see you in a minute. All right, end scene. So in this scene, this is what some providers may consider consent to be. Sarah said, okay, fine, but her tone and body language and the words she was using conveyed that she was not comfortable with it. And I never gave her the option to decline. I only gave her the option to say yes. So that was not informed consent. I would say that's a pressure situation. Okay, so scene 2, we've already done, I've asked her to undress and I told her I'm going to check her, see where she's at. And she says, but I don't think anything's changed. So I will say, well, Sarah, we don't have to do the exam today. We like to check to see where things are at, but it's not necessary. Would you like to skip the exam today?
Is that okay? I don't really like having an exam unless it's necessary, but if you think I need to do it, I can.
It's nice to know if you're curious, but it's not necessary. It's just some information we like to have to put in the chart. So we start offering to check once our patients reach term. But when I see you next week, I'll offer again. Just remember, it's not a requirement.
Okay, I'll be a little bit closer to having this baby next week, so I'll think about it. But I think today I'm good.
Okay, great. If you don't have any questions, then we're all good. You can go to the counter and make your appointment for next week. Okay, so Sarah, you want to tell us what was a little bit different about that one?
So the patient, me, I never say no outright. And I'm a little unsure, but what is different here is not, it's not a perfect example, but the provider is like paying attention and seeing my no, even if I'm not saying it. And they're the one that says, oh, like, yes or no, like you have a choice here. They're the one that like kind of reaffirms my autonomy. And even though that's the standard operating procedure at the practice, that gives me the way to, without ever saying no to this authority figure, not have the exam I don't want to have.
Yeah, good. Okay. So scene 3, I've told Sarah to undress, explain that I'll have a better idea of where you are because she's 37 weeks. And she says she feels the same as she did last week. But
Okay,
then you say,
what does a check include?
so I'm going to use my fingers to check your cervix. It involves a vaginal exam. That way I can tell if you've dilated, if your cervix is soft, if it's low or high, if it's firm. It gives me an idea of where you're at now that you're at term.
Okay, I'd like to know that too, but I don't really want a sweep. I've heard about those and they hurt, so I don't want to do that today.
Oh, of course. So a cervical check is not the same thing as a membrane sweep. We can talk about membrane sweeps maybe next week if you like, but I would never do anything like that without checking in with you first. During the exam, since you want your cervix checked, we can always stop if you get uncomfortable or change your mind about what we're doing. So during the exam, I'll be inserting my fingers into your vaginal canal to check the exterior or the outside of the cervix, but I won't insert them into the cervix itself. That's not necessary for me to measure dilation or to check and see how soft your cervix is.
Okay, yeah, that sounds good. I don't want to sweep, but I'm fine with an exam. I'd like to know what's going on.
Okay, great. I'll go ahead and step out and come back in a few minutes with our nurse. Okay, so in that scenario, Sarah was not really sure what the exam included, and she did not want the sweep. So she clearly communicated that with her provider, and the provider was respectful and educated her about the difference between a membrane sweep and a cervical exam, and also I encouraged her and let her know I won't do anything without her explicit consent. All right, time for our last scenario. And this is where Julie's coming in. So Julie's going to be the companion in the room. And in this scenario, I have, again, told Sarah to get undressed and get the blanket on, and I'll be back in a few minutes because she's 37 weeks and we need to know where baby's at. So Sarah says, I really feel the same as last week. And I'll say, okay, I'm just going, oh, wait, I'm on the wrong one. Well, we won't know for sure until we check. It really won't take that long. We'll have you out of here once we finish the exam.
Well, can the exam help prevent any problems?
Good question. It doesn't prevent anything, but it lets us check on the cervix, which we like to do once we are at term. And we do it with all our patients. It's standard care.
I don't know. I don't really like these exams.
What would happen if we didn't do the exam?
Well, we won't know what's going on unless we check on things.
I don't know.
Sarah, do you want to do this, or do you want to skip the exam today?
I'd like to skip the exam for today.
Are you sure? Don't you want to check to see if you're dilated? It's important for me to have this information.
We really thank you for the offer, but she said she wants to skip it for today.
Yeah, I just don't want to do the exam right now.
Okay, if you feel that strongly about it. When I see you next week, we will need to do it then, though.
Is it a requirement at 38 weeks? I mean, what does it help with?
So knowing if she's dilated is really helpful, especially if we're going to do an induction, since most of our patients are induced at 39 weeks. So that's why we check.
Oh, well, I'm okay not knowing how dilated I am. I want to wait and see because I was just kind of hoping for things to start on their own. I feel good. I don't have anything going on, like you said. So if I want an exam, I'll ask next week if that's okay.
Okay, well, if you don't have any other questions and we're all finished, you can go to the counter and make your appointment for next week. Okay, so Sarah, what were your thoughts on this one?
I think in this scenario, having my lovely companion Julie was really helpful. I was, maybe I knew I didn't want to do this, but it was like a little bit waffling under the authority and the rules and the
The
routine.
white coat.
Yeah. And
Yeah.
having my companion there just to kind of like help me ask questions, maybe, being the quote unquote bad guy, even though there's no bad guys here, obviously. And also having them be the one to be like, hey, this is a yes or no. Kind of helped me to feel a little bit firmer on my feet, so to speak.
Julie, what did you think? What were some of the red flags that came up for you with this appointment?
Yeah, the idea of the standard care and just the where we induce all of our patients. So it really just seems like it's so much more about the information that the doctor wants to know as opposed to the information that is needed or that the patient even wants to know.
Yeah, and a lot of people in the chat are talking about, wait, what? Like the induction thing? And so this is where the conversation was really helpful because it revealed information. You'd rather have this now than, find out at 39 weeks or at the next appointment when they're like, it's time to schedule your induction. And you're like, what? So now you know the routine practices at this clinic. So really helpful because now you can regroup and figure out what you're going to do about that. So yeah, great conversation. Thank you, Julie. And like I said, we tried to give several different variations. So we gave you an example where Sarah was pressured into the exam, a scenario where she declined the exam and the provider was respectful. A third where she accepted the exam, she wanted the exam and she gave informed consent and clarified about the membrane sweep. And in then scenario 4, She declined the exam, and I would say the provider was disrespectful. One thing I also noticed as the person playing the provider in this skit is that I kept saying like, we check this, we need to do this, we do this. It's time for us to see where baby's at, kind of like almost like I don't think it's on purpose. I think doctors are often trained that way to use this we language to act like Sarah's already on board. It's something we're all doing together when it's really me. Like I've decided that, right? So it's kind of like using this royal we or something. It's a little weird. So did anything else strike you from these scenes? And then we'll get to the questions in just a minute. Oh, yes, I know. It is a little triggering. Some people are like, these hit a little too close to home. Yeah, depersonalizes it, makes it feel like policy. And it was definitely helpful, I think, you having that. I think if you had had the companion and seen one, you wouldn't have had the exam, right? That was kind of like what an unsupported person would experience.
No, for sure. And it's interesting, like kind of putting myself in this position because I had a very much wanted membrane sweep. I had preeclampsia just this April, and I had a totally different experience. I really had to like put myself in these shoes because
Yeah, because you said you had respectful
midwife,
care, midwives. They would have
exactly.
never done this to
Never
you.
in a bajillion years. I had to bring it up.
You had to ask for the membrane sweep. Yeah. Yeah, somebody said the we language made me feel like the patient was up against a group of people. Yeah, it's intimidating, that's for sure. But it's really familiar sounding. All right, so we are going to start the questions in just a few minutes. Go ahead and post your number one takeaway in the chat, and I'll come back and read them in a minute. So I'd love to know what surprised you, what you're going to remember, what you're going to take away. If you're pregnant and having a baby yourself, maybe what's one thing you want to use? If you are a birth worker, a healthcare worker, what's one thing you're going to change about how you educate or practice? Okay, so we did the evidence, we talked about advocacy, and next we're going to talk about EBB resources, the QA, the handout, and we'll end with the prizes for those of you who hang out with us the whole time. All right, so some evidence-based birth resources. So a lot of people will say, when have you covered this? Have you covered that? I just want to let you know you can go search the evidence-based birth blog and find all of the content we've published on various topics. And that is on the main homepage, evidencebased-birth.com. We also, this will be in your handout, a list of episodes that I think are really relevant to this. So we go into more detail about the evidence on membrane sweeping in episode 151. Episode 277 talked about induction for prom. 278 is really focused on an innovative Afrocentric model of prenatal care that's really respectful and holistic. Episode 180 is with Dr. Stephanie Tillman, the feminist midwife, about trauma-informed care and consent with pelvic exams. So that one is highly relevant to today's discussion. 208, we talk about advocating for your rights in care. 303, bodily autonomy in pregnancy and birth. And 332, that's the one coming out next week with Dr. Leslie Farrington about advocating for yourself in prenatal visits. And she gives a bunch more tips. So that'll be coming up next week. Also, if you're pregnant, we do have a comprehensive evidence-based birth childbirth class. You can find your class at ebbirth.com/childbirth class. And I was just looking, I took a screenshot of just a few of the classes that are coming up in the next few weeks and starting. So you can search there. Most of them are virtual, but some of them are in person and virtual. And then also exciting news is that the EBB Pro membership is on sale. You can join now through October 18. Save 20% on some options, all the way up to 25% on one option, and get immediate access to cutting edge CEUs. If you liked this training, we have tons of trainings like this, and a supportive community of birth workers. So what's included in the EBB Pro membership? We try to put everything in there. So you get all the courses, you always get the certificates with the course. You don't have to pay extra for that. We have trainings like this once a month that are live, and then also you can have access to the recordings for up to, we keep 3 years of recordings in a library. We have a thriving community of other birth workers and healthcare workers, member exclusive PDFs, so you can print off and hand them to a client whenever you need. We also, in the last year, launched a doula mentorship as well as a midwifery mentorship. Those are group calls that happen once a month. And then we have sneak peeks of articles and topics. I can tell you that the pro members will have the first peek at the new signature article on the ARRIVE trial about induction at 39 weeks. So that is coming up in the next couple of weeks. And then we also just launched the 2024 flu vaccine training for flu season. And this is a screenshot of one of my favorite trainings from the last year, all about intraamniotic infections. So talking all about how do we manage infections during labor and the babies after birth. So that's an example of like kind of the level and quality of trainings you get. The continuing education is good for nurses, doulas, childbirth educators, certified professional midwives, certified nurse midwives, certified midwives, those who are seeking the midwifery bridge certificate, and physicians. So our contact hours can be used for all of those categories. So you can join now at the reduced rate. So 20% off the monthly or annual options. And then the best deal is the quarterly option at 25%. So you would pay every 3 months, and that gives you the best savings right now. So how to join, it's pretty easy. Our team will put the link in the chat. We'll also email it out later with other resources. So you would just fill out the form and start the term, and you can see the sale price will show up. The coupon code should be automatically applied. But if you have any questions, just email us, respond to any of the emails we've sent to you about the webinar. We've got Julie, we've got Jen, Shantae, and Ricky, who are all here all over the next couple weeks to help if anybody needs help. All right, I think it's time for our questions and answers. So stop sharing my screen. And oh my goodness, there's like 24 questions. So, all right, have you seen any, Sarah, that you want to look at?
I think I've been seeing them come in through
You
the
can't see
chat.
them in? Okay. Oh, I think I might have to make you a co-host in order for you to see them.
I can see the Q&A, yeah.
You can?
Mhm.
Okay. Well, let me know if there are any questions that jump out at you. I'm going to scroll through and find a couple. So we're focusing on the cervical exams during pregnancy. Some people have questions about during labor. It's a bit different of a rabbit hole or topic to go down. Yale asks, how can you tell if a membrane sweep is being done during a cervical exam? So you can ask, of course, are you doing a membrane sweep? But it would be more painful, and sometimes you don't know until afterwards when you experience bleeding and contractions. Then that's likely that it was done, because the research shows pretty consistently it causes bleeding and uterine irritability. So you'd have cramping afterwards. Let's see, some of these we covered, I think, is they asked the question and then we covered it. So the handouts we'll give in just a few minutes. Yeah, somebody says, I want the evidence on cervical checks during labor. I will tell you, Sarah W. asked this question. I don't think that it's ever truly been studied in terms of like randomly assigning some people to have. Now there might be one study. I take that back. I think there's one, because I had a student do a research project on this, and I believe she found one study. But I don't think anybody had 0 checks. I think it was like a randomized trial where you could have during labor, a cervical check every 2 hours or every 4 hours. I think they didn't give you the option of none. And I don't remember what the findings were, but it always bothered me that they didn't have a true control group that received. I'm gonna take that off. I don't need my stethoscope on anymore. Do you see anything, Sarah?
There was a question in the chat, maybe more of a comment, or people were talking about sort of like, this is a lot of information. And
Yeah.
in my personal experience, this is what I do. Whereas my partner, my husband, not so much for him. And I know he kind of felt overwhelmed. He also didn't want to leave me to do all the knowing, he wanted to be able to advocate. And finding a really good childbirth education class was really important. The EBB course was really helpful to us. I have a friend in another country who's an educator, and we took one of her classes. And just remembering too that, you don't have to know everything. It's kind of, like, how do you eat an elephant one bite at a time? Even knowing everything doesn't necessarily, guarantee everything will go, it's good to know, but don't be overwhelmed. Someone said that information is empowering, and that's absolutely the case. Whatever you can learn, whatever you can find out, helps.
Yeah, I agree. And I think something we cover in the childbirth class, we talk about what we call the golden ticket, which is, I mentioned earlier the importance of a trusting relationship with your provider where you really can communicate with them. If you have that relationship, some of what we talked about tonight does not apply to you, right? Because if you have a provider who's trustworthy, I should say that, not just somebody you trust, but they're trustworthy and they've earned your trust and you have that relationship, they won't do these things against your wishes or pressure you. So that's something to remember too. Like some of the scenarios we gave were really, some people said they were triggering and hard to watch. And I think we have to remember it's like quite common in the obstetric like just the routine care because it's a box they have to check, right? It's part of their routine. The midwifery model of care does not have that. So this is something you would rather not even have to worry about. As you saw in the poll, most midwives don't recommend routine cervical checks. So it's partly a model of care issue. But then there are also plenty of obstetricians who are very respectful and won't push the exams on you. But with any profession, you have like such a wide spectrum, right? Of poor quality all the way to super high quality. So it's kind of getting a feel for where you are with your provider.
Somebody asked about the terms. So membrane sweep might be the most common. Membrane stripping is also commonly used. In some cases, they may use the term intra-cervical exam, kind of emphasizing the insertion of the digits. I also know there were some questions about the internal versus external os in a cervical check. If you wanted to.
Yeah, I think what we were trying, so yes, they might put their fingertip right in the hole to measure it, but they're not going to be inserting it inside the uterus, if that makes sense, in just a simple check. So I think that's what we might have not had the most clear language.
Yeah. Oh, and someone else brought up brain and brand. So other handy acronyms.
Yeah, brand is easy to remember. Benefits, risks, alternatives. What if we do nothing? Let us discuss and decide. And then brain adds I for intuition. I think cervical checks don't require really a lengthy discussion. To be honest, there's not a lot of information to convey. And if most people will know in advance if they want it or not. But membrane sweeping, that's the actual procedure. So it's a little bit different in terms of like you're intervening and changing things. So a lot of really good questions. Thank you so much for all of the amazing discussion. I didn't get a chance to check in the chat to see what people were saying were their takeaway points. While I'm pulling that up, Team EBB, can we do the prizes and the handout, please? And I will pull up the chat with the...
I just entered the link into the chat for to enter into the giveaway. So it's just a simple Google Doc form that'll give us your name and email. And go ahead and fill that out now while Rebecca's looking over the chat.
Awesome. Okay.
Also, if anybody, could you all remind me of our email if anyone needs to reach out, they have a question or
info@evidencebasedbirth.com.
Yeah, I think there's like a student who had a particular question for that. So
yep.
Yes, and I didn't mention we do have student scholarships as well. So make sure when you're checking out the pro membership, check that out for our students here. Okay, so
another
people,
30 seconds.
All right, yeah. While you're waiting for the wheel to spin, So go ahead and enter your name before, and
They're
Jen will
still
give
rolling
us-
in. I'm going to give you guys a few more minutes. Only one entry is you can't do it multiple times. It will
Yeah.
not go up.
She will delete the multiple entries. Don't make Jen salty tonight.
All right, I'm
Yeah.
gonna go ahead and close it down here, guys.
People like the role play. Somebody said the doula seemed to speak too much. I think, we didn't say Julie was a doula, just that she's a companion. And I think she was backing up Sarah, who was nervous and afraid to talk. So I think it was okay. I think they had a relationship. They weren't just strangers, right, Sarah?
Yeah, no, for sure. I guess I was kind of drawing from my partner's relationship with our midwife, where he very much was able to ask questions and engage and learn alongside, another brain in the room to kind of help hold all the information. But yeah, that relationship between a doula and a person or a partner, like people were saying ahead of time, figuring out, okay, like, how would we like to handle this? Like practicing, kind of imagining can be really beneficial to find what works for each person, because everyone's dynamic will be a little bit different. That could definitely be overstepping for some people, whereas for others that might be the
What you needed.
exactly.
Yeah. And I think Julie never said anything that you weren't conveying. She was mainly just asking questions and then amplifying your voice.
All
Oh,
right.
somebody said there's providers that will fire their patients for declining. That's a whole nother that's a extreme level of pressure, right? So, okay. Oh, look at
All
that
right, you guys
beautiful
ready?
wheel. Wow.
All
What's
right.
the prize right now?
The prize is hold on a second. Oops, wait a minute. Let me take a look here. I did it again. Hold on a second. Shantae's yelling at me. I do this all the time. I have way too many windows open, folks. It's just, there we go. All right, Shantae, I'm on it. Okay, the prizes are the podcast listening guide. That is what we're going to be giving away first. And we'll go ahead and spin this wheel and see who's going to win that one.
And we just had someone in the chat say they're hooked on the podcast. They're not even pregnant yet. So they're learning way in advance. That's amazing.
There we go. Okay, so Linda, we'll be emailing all of you afterwards to get your shipping address, but we will go ahead and get that out in the mail to Linda Livingston. Congratulations. Number 2, we are going to give away the induction pocket guide. We do have it in physical format, which, do I have it right here? Yes, I do.
Yeah, I was going to say, we have a few left, right?
I always have my induction pocket guide.
I have mine.
So it's not on the right page, but, oh, you got it too? Yep.
Yeah.
So these are really nice and handy for parents to have in there.
And they're not in the shop right now physically. So it's a special treat.
It's a special treat. All right. Let's see what that tiny little dot. Tamara Rowland. Good job, Tamara. Congratulations. You're going to get that induction pocket guide. And the last one is an autographed copy of Babies Are Not Pizzas.
The spinning EBB.
I know. Kind of makes you dizzy. These are a lot of names on here. All right. And Sydney, I love the spelling of your name, Sydney. Sydney Gaines is going to get Dr. Decker's autographed copy of Babies Are Not Pizzas. So congratulations, everybody.
Congratulations. Thank you for being here. We've had so many good conversations in the chat and everybody's been respectful. Thank you so much for attending and for learning and just soaking in this knowledge. It was fun being here with you. Last, words of encouragement. Hopefully just take one thing away from today that you remember. I know this was a lot of information. Some people asked about the recording. We'll email it out probably tomorrow. It has to process. So we'll email out the recording tomorrow. You'll have access to it through October 18. Of course, if you join as a pro member, you'll have access for as long as you're a member to all of our trainings. And actually somebody mentioned about the doula speaking up. We had a whole training about that. I think that was in August. So we've been talking about the history of doulas and doula advocacy inside the EBB Pro membership. So thank you everyone for joining. It's been wonderful. Stay safe for those of you in Florida. And we will have another showing of this identical content next week. So if you have friends or family or colleagues that you think would benefit from this, or maybe there's a group that wants to listen to it together, make sure you tell them to go to ebbirth.com/webinar to sign up. So thank you, everyone. Bye.